welcome you to the Let Us Dream 2020 Triennial International Virtual Conference on behalf of the entire International Conference Planning and Organizing team. They have been working tirelessly preparing for this event since January of this year. In fact, this conference is the outcome of a journey of more than 100 volunteers from different cities, countries, and cultures crossing three different continents: Asia, Europe, and North America. The path along this journey was an emergent one, not without its challenges, but one that was spawned shared commitment within our team to bring you the Let Us Dream conference, with its aspirational theme connecting local communities and service initiatives through global networking. Consequently, we are delighted to be able to provide you with a program consisting of an illustrious group of diverse, talented, and dynamic speakers, panel discussion members, and unsung heroes, all of whom have selflessly given of their time, expertise, experience, and effort to bring this conference to you free of charge. However, first let us take a look at the genesis of this conference and how it has evolved into this year's International Virtual Conference. The Let Us Dream Conference was a vision of Dr. Father Lijo Thomas, who saw the need to create a forum for professionals, scholars, researchers, and post-secondary students to connect and share experiences in implementing community improvement initiatives. Out of that vision, the Let Us Dream Conference was launched in 2017 at Louisiana Tech University in Ruston, Louisiana, USA. The overarching purpose of that conference was to provide opportunities for networking, sharing community improvement models, and developing the next generation of community leaders. The conference was a great success with approximately 200 people in audience. The Let Us Dream 2020 Triennial International Virtual Conference was a vision of empowering local communities, evolutionary outgrowth of that first locally sponsored conference in Louisiana. Since that first conference, annual Let Us Dream conferences have taken place at 5 universities in 3 different countries. We would like to take this opportunity to extend our deepest gratitude to these 5 host universities, where the Let Us Dream conference has already been established as an annual community event, and for supporting, promoting, and participating in this year's conference planning. Also, we want to extend a sincere thank you to the numerous partner organizations who have assisted us in promoting and marketing this year's international conference, as well as providing their expertise in various planning committees. Before we begin the day with the opening address, I invite you to join me in observing a moment of silence to connect each other beyond our boundaries and pray for the healing and harmony in the world. I would like to now introduce our opening comment speaker, Dr. Harvey G. Stenger. Dr. Harvey G. Stenger was appointed President, Binghamton University in 2011. At Binghamton, his emphasis has been on strengthening academic programs, expanding research, and promoting economic development. Most recently, he has led the university's response to the COVID-19 pandemic. He has served in administrative roles at the university at Buffalo and Lehigh University. Dr. Stenger earned his PhD from the Massachusetts Institute of Technology with a research focus on synthetic liquid fuels.
Thank you, Ms. Rao, for that generous introduction, and thank you for letting me open Day 2 of the Let Us Dream International Conference. Over the course of this conference, more than 25,000 people will participate in learning how to build networks that are sustainable, that can help our communities. We were fortunate enough last year to host the conference live here at our College of Community and Public Affairs. And one of the benefits of hosting a conference, especially the live ones, are the participation of all the people that helped to organize it, from our first-year students to our most advanced faculty members, working together to create an itinerary, an agenda, and to host that conference was a great experience. I can imagine that what's happening right now to pull this one together virtually is just as challenging and perhaps in many ways more challenging. The model of education that we use at CCPA is that the research has to inform the education of our students by their internships and service learning in our local community that has a real and measurable impact. These internships provide a tremendous experience for our students to learn the impacts of service learning and community engagement on the entire world, and their experiences will help those partners in the future. The topic and theme of this conference has a lot to do with healthcare. And what better thing to be discussing right now as we're in the middle of this pandemic, but how we can support the healthcare systems around the world. Today's keynotes and panelists are going to discuss two critical issues. Mental health, probably the #1 concern right now in our nation and in the world. And secondly, the disparities of healthcare that people have access to, not just here, but everywhere in the world. Certainly, I want to thank the team leaders, panelists, moderators, and keynotes who are providing valuable information to our audience, and I know it was a lot of work to pull this together. Certainly, we want to thank Christ University in Bangalore, India. We want to thank the Catholic University of Applied Sciences in Germany, our own Binghamton University here in Binghamton, New York, Louisiana Tech University, as well as Grambling State University. Thank you so much for pulling this together and partnering in such a great way. And of course, I'd like to thank my friend, Father Lijo Thomas, who helped organize this conference, but also is the founder of the Let Us Dream organization. Thank you so much, Father. I hope to see you soon. And I want to thank the thousands of people who have watched and participated in this conference. While being virtual isn't always the best thing, it does have that added advantage of being able to reach so many people in such an efficient way. So thank you for being part of this conference as well. I hope you have a great conference. And here's your assignment. Listen carefully, take notes, and especially bring those ideas back to your organization and implement them. That's the goal of a successful conference. Thank you for joining me. I hope to see you in person soon.
I would like to now introduce our keynote speaker, Dr. Philip McCallion, Professor and Director, School of Social Work, Temple University, Philadelphia, USA. Dr. McCallion's research interests fill an important niche in the field of social work, bridging scholarship on aging populations and those with intellectual disabilities such as Down syndrome. He is co-principal investigator of the Intellectual Disability Supplement to the Irish Longitudinal Study on Aging, a visiting professor at Trinity College Dublin, A. John A. Hartford Foundation Social Work Faculty Scholar and Mentor, and a member of the Steering Committee of the National Task Group on Intellectual Disabilities and Dementia. A renowned researcher since 1996, Dr. McCallion has received more than 30 million in research funding and has published more than 140 articles on interventions with older adults with chronic conditions, caregivers of frail elderly, persons with Alzheimer's disease, and persons with intellectual or development disabilities. As a mentor to junior researchers, he has served on 23 doctoral student committees, of which he has chaired 14 and supervised 40 doctoral and master's projects. Dr. McCallion's research began with randomized controlled trials of psychological interventions for people with dementia and their caregivers. His interests have extended to creating aging-prepared communities, evaluating non-pharmacological interventions, increasing the research reach of palliative care programs, and developing community-oriented projects to assist aging persons with intellectual disabilities. Within this work, Dr. McCallum emphasizes evidence-based interventions, collaboration with state and local agencies, and community capacity building.
I'd like to thank the organizers for inviting me to deliver this keynote on health. As you'll see in the first slide, I also wish to acknowledge Lisa Peretti, who is my colleague and partner in the work that I'm about to discuss. I always begin my consideration of this work by thinking about this issue of chronic illness. You'll see here on this slide to the left-hand side that the top 10 global causes for death. There are two on this list that are of particular interest to me in the work that I do. Heart disease and diabetes, particularly type 2 diabetes. These are non-communicable diseases. They are often lifelong in terms of their implications. And they require that there are things that I do as an individual, but also that there are ways in which the community can either support me or can make my life more difficult with those diseases. To the bottom right of this slide, you'll see much of my work is done in the United States. And so I look at that 6 in 10 adults in the US have at least one chronic disease, and 4 in 10 have 2 or more. And these are the leading causes of death and disability and the leading drivers of our annual healthcare costs. In the top right corner, I also want to talk about the linkage between physical health and mental health, which is one of the themes for the health section. People with other chronic medical conditions have a higher risk of depression, and people with depression are at higher risk for other medical conditions. And yet, even when other illness is present, depression is treatable, so that there's a complex interaction between physical and mental health that we really need to be concerned about and involved with. But when I think about these chronic conditions, I'm not a physician, but yet I think I have an important role to play in how we manage our chronic conditions. And I think that largely because of the social determinants of health, that we realize that so much of what happens from a health perspective is influenced by all the other things that go on around us in our lives. Our income, the physical environment, our employment situations, our levels of literacy are all important. But also there are things like healthy behaviors, there are things like access to health services, what about the levels of social support that are available to me, and what's the impact of gender in the midst of this, and how are we permitting gender to perhaps influence access, for example, to healthcare. And so I think that these are areas where, as individuals and as communities, there are things that we can do that will improve the management of chronic conditions for everyone. So this next slide has the chronic care model, which is something that really looks at the relationship between formal healthcare, between health systems and the community and the individual. And I draw your attention to that idea that there is an activated community that includes informed, activated patients, and that productive interactions and relationships involve their interaction with practice teams, with community partners, as well as the healthcare system. And that's how we arrive at good outcomes. So in this slide, I'm really interested in trying to understand the linkages, certainly between health determinants over the life course, but also health outcomes and its distribution in the populations that I work with, and then to look at the interaction that policies and other interventions at the individual and the population level can have on whether it's influencing determinants of health or influencing health outcomes. So as I work to develop and test and encourage interventions, I'm also greatly influenced by what we call the RE-AIM framework. RE-AIM is reach, effectiveness, adoption, implementation, and maintenance. Really causes us to sit back and think about, well, the evidence says that this intervention will have a great effect, so why doesn't it happen? Well, it doesn't happen perhaps because we're not reaching the right people. It doesn't happen because there aren't organizations who either are able to or who want to adopt it. It doesn't happen because we don't implement it in the right way. And often it doesn't happen because we have no mechanism for maintaining an intervention once we start it with great fanfare. So effectiveness is still important. That's the other component that I haven't addressed just yet. But let's think about sort of what does it mean to say that an intervention is effective? I think an intervention is effective when it becomes widespread in a community. I'm less interested in an intervention that only works for 3 or 4 people. I know it's important for them. There are other people who will do that work. That's not the work that I'm focused on. I'm focused upon interventions that will become widespread. And so with that in mind, I want to give an example from my work on building healthy communities of sort of the kind of work that's done and the kind of issues that we need to be thinking about. So this was the Healthy Hearts on the Hill Coalition. And it was a genuine coalition of a group of neighbors. And as a university, we were one of the neighbors. We were in a community called West Hill. And the community decided that they wanted a project that would mean that their neighbors would have the means and access to live heart-healthy lifestyles within the community and supported by the community. So we started out with some particular strengths, and each community is a little different. What we were fortunate to have was that we had developed some programs already, like the Neighborhood Health Advocate Program, that was serving a very, very small number of people. We had the faith communities in West Hill who were organized and who wanted to make a difference. We had a medical school that was nearby that had a small community service program and was willing to partner with us. We also had capacity for evidence-based health programming, and that had been demonstrated effective in individual behavior change, in which if the community was interested, we could very quickly stand up capacity to deliver those. But I think the most important thing that we had was that there was an interest among the agencies and individuals in the community to build a coalition. And there was an interest in doing this in a partnership way, in a participatory way. So when I think about traditional community change strategies, we tend to choose a unit for intervention. We're either largely focused on individual change or we're largely focused on community change. And yes, there's a lot of communication back and forth, but we're interested in understanding what that means for the individual or what it means for the community. In our coalition, we wanted to do something a little different. We were really interested in a community change strategy that really mobilized the individuals in the community. We worked on partnership building, we worked on co-creation of community-based programming, and we utilized evaluation to understand what the impact was at both the individual and the community levels simultaneously. Not one or the other, but both. So we then sort of really targeted in on sort of, well, where do we want the change? What is it that we're doing? What are we targeting? And we certainly looked at the system level, looking at the health providers, the structure of healthcare delivery. But we also looked at the role of faith and community-based organizations in promoting change. And we looked at the roles of individuals, businesses, of the social networks that already existed in the community in promoting change at all levels. And then we looked at how well we were building community-driven solutions, a strong coalition where we mobilizing the community, were we advocating, and where should we advocate for systems change at the level of policy, regulation, and practice? It was a grassroots effort, certainly in support of individual behavior change, but something that was permeating the whole community. We looked at offering screening programs to build greater awareness of the chronic conditions. We looked at referral systems for primary care. Many times the most challenged communities have the least access to care. So we worked on sort of how do we ensure that that access is available. And we targeted our programming at the major risk factors, in this case for cardiovascular disease. We looked at nutrition, we looked at physical activity, we looked at helping people to stop smoking, and we looked at chronic disease self-management. I can tell you the best ways in the world to improve the care of your chronic condition, but I'm not going to be there every day, 24 hours a day, to help you with that. Really, I need to be working on how do I help you to manage these things for yourself. And so that's why we had such an emphasis on chronic disease self-management. But it was also about creating a community that would support all of this. So we focused in on increasing community awareness and education. The screening events were a good example. We looked at increasing access to healthy foods. We talk about food deserts as being a problem. Again, that's sort of people who have poor access to transportation, who have chronic conditions, often have the least access to healthy foods. And so how do we increase access in the community? And there were a variety of strategies, often very low cost and very effective, to bring healthy foods in, including helping people with understanding how to cook those healthy foods. And then we also looked at the issue of physical activity, and we realized that it was about increasing access, but it was also about creating safe physical activity spaces. And so as a community, we worked together on that. Then again, because our interest was in engaging at the community level, we wanted this to be something that everybody in the community was aware of. And it was really transformational. So we organized something that we called the Biggest Winner. So it was a contest that we ran for several months, from April to December in the year that we ran it. It was modeled after a TV program in the United States called The Biggest Loser. And that's a program that really focuses upon helping people to lose weight. But the people in our neighborhood said, everybody thinks we're losers. We don't want to be called losers. There's nothing to be gained by being the biggest loser. And so we decided, okay, then we'll be the biggest winner. So we targeted the three major means of health-related behavioral change: nutrition, physical activity, and healthcare monitoring and management. And what we wanted to do, and what we succeeded in doing, was getting people to commit for a period of 4 months, that each month they would do activities that within those three areas, and that they would get points awarded for the activities that they did, and that people would commit to 4 months of these activities and to gaining at least 30 points each month. And if they did that, they'd be able to qualify then for a grand prize drawing. But at the same time, anyone in any month that turned in a scorecard would also be eligible for monthly prize drawings. We targeted 3 communities, West Hill and the 2 neighboring communities of Arbor Hill and the South End. These are very challenged communities. These are often the communities that are an entry point for immigrants to upstate New York. These are also communities where there are groups that have lived for a long time, and they are also communities where there's often a lot of transition in housing. It is a very ethnically diverse community. 20% of the population is over age 65. Almost everyone is low income. And about 35% were below what we call the federal poverty line. And these are communities that are health disparity areas, that there is a disconnect between the level of need and the services that are being provided to people. There's also issues in these communities of crime. There are large numbers of children who've been designated as at risk, and a lot of shut-in older adults who just didn't leave their homes very much. What really worked in this community was, and for the Biggest Winner contest, was that we engaged with organizations to be partners in this campaign. They became the places where people could go to get information, to register, to participate in activities. We ended up with 238 people who committed to the 4 months and got their 30 points each month. But we probably had about 1,500 people who participated overall in activities held at the portal sites. We were highly successful in engaging people who are most at risk. For example, among our contestants, the diabetes rate was 24%, which is about 3 times the rate in the rest of New York State. And about a third of our participants smoked, which is higher, again, than sort of the typical rate in New York State. So this was not about getting people who were ready to make change and who didn't have a lot of change to make to be healthy. We were really targeting people who really needed these programs. We used evidence-based programs such as the Chronic Disease Self-Management Program. We built a workforce in the community, largely of volunteers, largely of people just like the people who were participating in the classes. We developed I can't say we developed, a sense of community really developed. We started seeing teams being formed at the sites, for example, walking clubs, groups who would go together to shop at the supermarket, and just teams of people who would work together and support each other in participating in the activities. We looked to link our existing organizations within the community with new ones to the neighborhood, for example, a food co-op, an Asian arts group, all of which were really working to support each other and to support the people in the community. But I think the most important thing that the Healthy Hearts on the Hill Coalition achieved was that when this work all started, a lot of people said, well, nothing's going to happen. Look at all the problems that this community has. You're not going to make a difference. And what really changed over time, and what the Biggest Winner contest helped us to highlight, was that the coalition was delivering. There were things happening. There was excitement about the competition. When we had that final event where we awarded the grand prize, it was standing room only in the hall that we were using. And we were using the largest hall that we could find in the community because it was important to us that it be in the community, that people see that this was something that was happening here and that it could happen. Some of the other benefits included that there were lots of personal stories among the people who participated that reflected extraordinary gains that they made in improving their health. And again, this was not something on a TV program or on an advertisement in the newspaper. These were people who you knew, who over the 4 months you saw walking much more, you saw had clearly lost weight, who could talk about how their A1Cs had gone down. And the other thing that we hoped for, but were impressed by, was that we saw people stepping up and volunteering to help each other. It wasn't just a case of, I'm going to do the activities. I want to help some of my neighbors participate in the activities as well. But it was that expectation of community change that we think was sort of one of the most important things that we did achieve, and which sort of helped to then sustain the activities that we had started. So we learned a lot of things during the project. Community organizing, changing a community is a lot of hard work. There's a lot of meetings. There's a lot of people to be talked to. There's a lot of challenges that will present themselves, and sometimes it'll feel like 2 steps forward, 1 step back. But yet it's still very rewarding work. It's important that you build strong relationships within the community, between the different organizations. That's how sustainability happens. It's not about somebody new coming in and doing something really great. It's about a partnership. And it's about people having the time to work with the group of people that they serve around these issues as well. It's about identifying champions and advocates for your program. And it's thinking about sustainability in every decision that you make. You don't do for people, you do things with people. That's how you create a legacy. That's how things will be carried on after you leave. Joel Barker said that vision without action is merely a dream. Action without vision just passes the time. And vision with action can change the world. So I'll add to that that you have to start with a dream. And I think that that's what this conference is about. It's about stating the dream, stating the vision. The next step is action. And so I hope that in sort of what I presented, that you see how one community worked on action. And it's the combination of the dream or the vision with the action that can change the world. You start changing the world by changing one community at a time. And so I want to thank Father Thomas, and I want to thank the universities that have organized this conference, and I want to thank the organizing committee that invited me to present. And I hope in some small way I can help articulate the dreams and talk about how action with those dreams can change the world. Thank you.
Coming up, we have 3 parallel panel sessions relating to the field of health. In selecting the themes for each of the 3 panels, our team considered current issues and problems that today's health sector is facing. The worldwide COVID-19 pandemic has created increased challenges related to practices for good health, mental well-being, and the healthcare systems we have in countries across the world. We are extremely fortunate to have assembled an international group of health experts representing many countries for each of these panel discussion themes. First theme of our panel discussion is on mindfulness for health. Our moderator, Sophia J. Woodward, is from Nashville, Tennessee, US, a higher education professional, public school tutor, consultant, empowerment speaker, and image consultant. Joining her on this discussion is Mansoor Ahmed from India, Mr. Prasun Datta, Bangalore, India, Ms. Dr. Suja Isaac from Bangalore, India. Our second panel discussion is on healthcare disparities, and our moderator, Dr. Kevin Washington, is from Florida and Washington, D.C., an African-centered psychologist licensed in Florida and Washington, D.C. He is joined by Dr. Tiffany Bates from Louisiana Tech University, Mrs. Malati Murthy joins us from India, and Mrs. Shashikala from the field of psychology for 15 years of practice joins us from India. Our third panel discussion is on healthcare disparities. Our moderator for this session is Dr. Seema Rani from India, founder of Heal Your World, a globally certified counselor with a vast experience in marriage and family counseling. She is joined by Dr. Vishal Rao from HCG Cancer Center, Bangalore, India, Dr. Camillian Woodard from Grambling State University, LA, and Ms. Amudha Robert from Lancashire, UK. You will be introduced to each panel moderator and panel members when the 40-minute panel discussion of your choice begins momentarily.
Let us dream 2020. I welcome everybody to this conference that we have been waiting for a long time now. Healthcare disparities is the topic of today that we'll be discussing with our esteemed panelists. I welcome the audience, I welcome the panelists, I welcome the entire team that is involved today with this conference. I would like to introduce myself. My name is Dr. B. N. Seema Rani. I'm the founder of Heal Your World, and I have been contributing as a mental health professional during this COVID-19 pandemic by doing a lot of research work and helping people cope with the mental stress they're going through. I would also introduce our panelists now. Ms. Amuda is a certified clinical practitioner in the National Health Service in Lancashire, UK. Ms. Amuda has more than 20 years of experience in the clinical practitioner field. As a clinical specialist, she has served the UK Society during COVID-19 pandemic. She has been recognized for her patients and awarded for best services in patients' critical care. I now welcome Dr. Cameron Woodard, who's received her Doctor of Medicine degree in 1989 from Louisiana State University. She is board certified in PM&R and in spinal cord injury medicine, and also holds memberships in multiple medical organizations, including Atlanta Medical Association and American Medical Association. Welcome, Dr. Cameron. I now welcome Dr. Vishal Rao, our third panelist, who's completed his post-graduation in otorhinolaryngology and fellowship in head and neck oncology surgery, and is presently the Chief of Head and Neck Surgical Oncology and Robotic Surgery at HCG Cancer Center, Bangalore. He also serves as editor of the Journal of Precision Oncology and has over 100 national and international publications to his credit. Dr. Vishal is an international advisor to the World Health Organization Tobacco-Free Initiatives and is a visiting faculty of Johns Hopkins University Leadership Programs. I welcome my audience, and I hope we have a great session discussing about healthcare disparities. Now, may I ask Ms. Amuda to speak something about what healthcare disparity means to her and what has she found most helpful in reducing the healthcare disparity?
Hello, everyone. Good evening. Well, it's afternoon in UK. I live in part of Northwest in England. So it's in the afternoon. So good afternoon to my colleagues and friends as well in UK. And it's a great opportunity for me to join with you all in Let Us Dream 2020 conference. And thank you very much to involve me to part of this. And thank you, Dr. Seema Rani, for your wonderful introduction. Thank you. Healthcare disparities. Disparities is differences. It's differences in health and healthcare between groups. It could be linked to a social, economic, or environmental disadvantage. It can occur in many dimensions. So it's related to age, gender, even sexual orientation, racial ethnicity, location, and the physical and mental disability status. So at present, it means a lot to address the disparities for the healthcare providers and healthcare workers in present situation. It's a matter for us because the disparities in health and healthcare, it's not only affecting the groups to face the disparities, and also it's just giving the limitation to bring in delivering the quality care. So addressing the health disparities is important for us because the population is becoming more diverse now. So when as a healthcare workers, when we focus these health disparities, We always just treat people equally, no matter whether they're young or old. We don't do any discrimination. We don't just think about their age or gender or religion or race, anything. So we always just support people. As an individual, we assess them and we help them. The diversity we all know, in this population, the diversity is becoming more and more. The diversity is usually, we are taking into account about differences between people and different groups to place the positive value to those differences. That's how we care for people. When I said we, we are like doctors, nurses, paramedics, and parapharmacists, and lab technicians, and other specialists and therapists, safeguarding team, and mental health, support workers. These are all people. We work together as a team to reach to people to help in the community as well as in the hospital. When I say about our team, being a nurse, I would like to just mention about the nurses' responsibility to address this health disparity, because we are standing in the front line to communicate with the people. And when we are assessing people, we address quite a lot. And our present world, I think we are more advanced nurses, not only just caring people. We expand our roles to the specialties. I work in the community, so I worked as a practice nurse and I developed as a clinical practitioner. So we do a lot to reach to people. I would just say that we all work as a team, and addressing the health disparities will help us to reduce in future.
Right. I think that's a very noticeable change that has come in our society. And thanks to people like you who have been actively involved in giving the right information and the right way to take these challenges in life. COVID-19, I'm specifically saying that. So that's a great information from you. Thank you for that.
Thank you.
And now may I request Dr. Cameron to introduce herself and speak about her version of what healthcare disparity means to her, how demographics like ethnicity, age, socioeconomic status, etc., influence care disparity.
Okay.
Healthcare disparity.
Good evening. I'm Dr. Cameron Woodard, and thank you so much, Dr. Seema, for that wonderful introduction. It is such a pleasure and an honor to be here to speak at the Let Us Dream conference. I do have a few slides I would like to show with my presentation. If you can pull those up,
Yes.
I'd appreciate it. There we go. Excellent. All right, so this evening I would like to discuss briefly racial and ethnic disparities in healthcare. And next slide, please. And health disparity, as defined by Healthy People 2020, is defined as a particular type of health difference that is closely linked with social, economic, and environmental disadvantages. And the key word for that, for health disparities, is difference. So in the United States, health disparities across ethnic groups have been recognized for over 30 years. And when I speak of ethnic groups, I'm including primarily African Americans, but Hispanics, Native Americans, Native Alaskans, and Asian Pacific populations. So why is this important? In the United States Census Bureau from 2020 states that as of now, there are about 4 in 10 Americans that are of ethnic populations. But it is expected by 2044 that number will be at least half. So health disparities, addressing that at this point in time, not yet. Go back to the previous slide, please, So health disparities is going to be very important for us to address going forward, just as far as cost is concerned. and to improve their health outcomes. So as far as health disparities, when did they begin? They start in the delivery room. And for the sake of brevity, I'm going to speak on African Americans because I am African American, but also because this research has been done mostly on this group. Next slide, please. Next slide. Okay. Anyway, it was a picture showing that healthcare disparities, go back one more. It was showing that healthcare disparities began in the delivery room. Back one more. And that is this, the research has shown that African-American women are 3 to 4 times more likely to die during childbirth delivery than other nationalities. And it's irregardless of their income, it's irregardless of education. So it does seem to be maybe related more to the color of their skin. So you can leave it right here, the slide right here. But as I was saying, health disparities start in the delivery room, and they continue throughout the lifetime of African Americans. And so some of the data has shown that African Americans are less likely to receive kidney transplants when they're on dialysis. They're also less likely to receive pain medication when they have bone fractures. And they're more likely to die prematurely from health disease and strokes. Next slide, please. So as we can see, some of this data that I have presented regarding health disparities will certainly impact health outcomes. So this slide that I have here to the right, as you look at the top, it has health outcomes. And we know that health outcomes are determined by the length of life, how long someone lives, as well as the quality of their life. But driving all of the health outcomes are the foundation, which are the policies and programs that are instituted in a community or in a government. And the policies and programs help to drive the health factors. So what I'll start with is some of the 4 health factors that are found to be very important as far as health outcomes. The ones that we as clinicians, doctors, nurses are most familiar with are health behaviors. And that is those where we talk to a patient about how they can improve their health outcome. If they smoke, we tell them to stop smoking. If they're overweight, we tell them to diet, exercise. Those kinds of things. If they're not compliant with their medications, we talk to them about that. So those are health behaviors, and those are important. The other aspect of health factors that we can address and we're more familiar with are the clinical care, and that is where we provide improved access to healthcare for our patients. In some communities, especially disadvantaged African American communities, there are very few hospitals or medical clinics for patients to go to. So we talk to patients about how they can get to places and get to the hospital whenever that's needed. But also making sure healthcare is affordable and available to most populations. So those are 2 2 types of health factors, the health behaviors and the clinical care that we are more familiar with as clinicians and that we address. But what I would like to bring to this presentation is the other 2 health factors that we don't really address and really talk about. And it's because I think a lot of us, we're either not familiar with it or we just don't realize the impact that it has on health outcomes. And that is our social and economic factors and physical environment. And why are those important? If we start at the very bottom with the physical environment, and we look at where a patient lives, where they may be near a factory, or as we call them, plants, where these facilities are spewing toxins into the air. That's going to affect their air quality. That's going to affect the water quality as well as the soil. So that's a physical environment. And as you can imagine, that is going to impact how a patient lives. Housing is important. Some people are living in old homes that have lead-based paint, and we know the effects of lead on children as they're growing up. So these are 2 physical environmental factors that also impact the health outcome of our patients that we normally don't address. If I move up the ladder to the social and economic factors, those are driving most of our health outcomes. And these are entities that we really don't even think about or address when we have a patient in our clinic. We start with, especially in disadvantaged communities where there's a lot of poverty, the communities are not safe. So you can imagine if we are telling a patient to improve their health that they need to walk more and they're in an unsafe environment, what are the chances that that is going to happen? That's more than likely won't.
Right.
So community safety is important. I go to family and social support. Sometimes we found, especially with some of our veteran patients, that they live alone, that they don't have family support. Some of it's due to mental illness. Some of it's due to just that they've lost contact with people. But we know that family and social support drive health outcomes. And the three last ones I'm going to cover under social and economic factors, and I think are very important. Education. In our disadvantaged, poor communities, the school systems in many cases are under-resourced. As a result, that is certainly going to affect their education, their educational abilities, their attainment, their cognitive abilities. And that in turn affects the type of job and employment that also impacts their income. And we know that people that are rich have more money, that are doing well off financially. We know that people that are educated, and in most cases, people that are white, have better health outcomes than the other group of people. So I think we go back to, again, starting with policies and programs that impact our communities through social economic changes, physical changes in the environment. I think as clinicians, the policies and programs are extremely important. I think they drive our health outcomes. And I think as clinicians that we would do well to advocate for some of these changes from a political standpoint so that we can help ultimately the health outcomes of not only African Americans, but Native Americans and other ethnic groups that have been adversely affected by health disparities.
Right.
Thank you.
Thank you. So that was interesting what you brought in. Social and economic factors, they contribute to 40%. And physical environment, which a lot of us forget to consider. So those are some interesting points you brought to notice, Dr. Campbell. May I now request Dr. Vishal to give his take on healthcare disparity and how health insurance, government policies, how these things are playing a role in reducing healthcare disparity. Dr.
Thank you,
Vishal.
Dr. Seema. Thank you, Dr. Seema. Am I audible?
Yes, yes.
Okay. I'm just sharing the slides here. Are you all able to see this?
Yes.
Okay, I just want to give you a quick introduction. I'm Dr. Vishal Rao. You've already introduced me. I'm representing HCG Cancer Center. We are a chain of cancer centers spread out across the globe. We have about 26 centers now, but we also have a presence in infertility. We've got some general specialty hospitals. We are a publicly listed company, and Strand, which is our bioinformatics, CRO, and clinical diagnostic wing, works on precision medicine in diagnostics. That's a little brief introduction about our center. As I told you, we are about 26 centers across the globe right now. We recently entered into Africa and Vietnam. And our model of hub and spoke has been studied by various schools, such as the Harvard Business School and a couple of other schools like Tuck and others, to study about how are we balancing healthcare models across the globe and how are we able to deliver affordable healthcare. And the context why I introduced our center was to tell you about how have we been able to balance these models. Now, fundamentally, what I would like to address through this discussion here is, when we talk about disparity, and I think Dr. Camblin very beautifully alluded to the aspect of defining disparity. I think the fundamental divide comes between health and disease. And I think the primary responsibility of healthcare disparity bridging would be the fundamental 3 points that I've alluded to below. Keeping people healthy, treating the sick, and protecting families from financial ruins. These are the fundamental 3 goals that define healthcare disparities for me. And what has been misconstrued often is that healthcare has been misconstrued with medical care, which is just about treating illnesses. So health is not about wellness, but it's been about illness all through in all governments. Unfortunately, if you look at the fundamental philosophy of medicine, and ideally a healthy society should have less doctors, less hospitals, and less illnesses. But it's gone the complete reverse way because we've actually marketed more of illnesses, and the fundamental structure of health seems to be tumbling down on us today. So, I'm asking some fundamental questions today to the audience in terms of health versus disease. Being a person who's managing diseases alone, but I also sit in policies with the government to say, let's talk about health. And every time I talk about health, they say, oh, let's build an hospital. And I say, I thought our discussion on health was actually about reducing hospitals, not about building another hospital. So if you look at the fundamental models, whether it's a patient, a hospital, or a doctor, I think this is the ecosystem. I call this the dynamic PhD, the patient, the hospital, and the doctor. Now, these 3 models, if you look at them, revolves around either the Beveridge model by the UK, the Bismarck model by France, the National Health Insurance model by Canada, or the out-of-pocket model like USA. There are various models that have been actually exemplified, and there's a mix and match in many of these places today. But broadly, I'm talking about the framework of things. And each of these, I think, would be very interesting for audience to study, out of interest to know how does each of these models bridge disparities, because that will fundamentally define to us how each model has been successful. And if you look at the global healthcare ratings, India is far below at, I think, 100 plus. But it's interesting to know what are the top 3 countries of the world doing to bridge healthcare disparities, and how do they actually bring it. And I'm sure globally nobody has got the magic mantra for this to say that I've bridged the complete one. There's been always a divide. But I'm just trying to introduce the topic in a very fundamental way to say that these are the broad models that everybody would need to study to address these. So, India is a very interesting hypothesis, and I'm saying I'm representing a healthcare center, and I'm telling you that we have a world within this country. We have the Beveridge model, the Bismarck model, the out-of-pocket model, and the national insurance model. All 4 models exist within one country. So we have the below poverty line, we have the government scheme like the Ayushman Bharat or the state government's below poverty line schemes. We have the employer schemes. We have the above the poverty line schemes, which I call OOPS, the out-of-pocket spending. And we have the beyond poverty line, which is the insurance for the elite. So you've got, I keep telling my friends in the West that, look, if you want to study the world, come to India, because you've got the entire world within India. You've got this model, you've got that model. I can take you within my state, I can take you to whichever periphery you want, and you'll have the data on every single aspect of it. So I believe, it's a very wonderful model that we are having. Yet we are struggling for balance. And I think that's very, very crucial that it's not that we've bridged the healthcare gaps. And the biggest gap that I feel in this is that every year in India, you see about 30 million people are getting into below poverty line only because of out-of-pocket expenditure. I mean, this is glaring data before us because, unfortunately, our GDP spending is about 1%. Whereas countries, something like UK would be spending 3% on research alone of its GDP. So naturally, we are seeing a lot of things that we need to bridge here. And I'm talking as a private healthcare provider who also believes in building a world within our center. So in our center, if you look at it, we have the government scheme, we have the out-of-pocket expenditure, we've got the government employer scheme models, and we have the insurance model. So in my center in HCG, I have all the 4 models working. The idea is that every patient who walks into this area is able to be given justification and treatment in a rightful manner, and we do not deny care for them. That is the fundamental rule of healthcare, that we do not, and that is what Camelin alluded to very beautifully in a presentation, understanding that we should not deny health, because health is a fundamental right. You cannot deny based on financial considerations, ethnicity, social reasons. You cannot deny healthcare for anybody. So I have just going to end with a couple of thoughts at this point that I feel the key thrust areas that governments and policymakers would need to look at is, one is, I think, very importantly, health impact assessment in these 4 models that I described. Health impact assessment, I think, is crucial to understand what is going to be the impact of policies, what is going to be the impact of funding, and how are we going to reutilize it. And I unfortunately believe most governments do not have an health impact assessment itself. It's very, very important strategically to keep looking at health impact assessment. So when we presented, for example, to the state government of Karnataka, my state government, I presented to the chief minister our overall health impact assessment on tobacco related diseases. I showed him that every year we spend close to 1,000 crores. That would, I don't know how many millions would that be. 1,000 crores would be into 1 crore is equal to a 10 million. So into 10. So it's about 10,000 million Indian rupees is spent on tobacco related 4 diseases, which is related to heart diseases, lung like tuberculosis, cancer, and cardiovascular diseases and strokes. So imagine the health impact assessment. Now, when I presented this before, when I said you only earn about 100 crores from the tobacco related taxes, but you're spending 1,000 crores on diseases, it makes a case in point to argue this to a policymaker and then say, yes, I want these policies to be done. I want taxations to be increased. I think that's crucial here. The second point I would like to emphasize on is health in all policies. I believe the biggest impact that health can perform is impacting non-health policies. So, for example, we are talking about the Municipality Act. We are talking about the Agriculture and Fertilizer Act. We are talking about the Sanitation Act. There are so many areas where health can be impacted, rural development. There are so many areas where health policies need to include. So I was telling my honorable minister that, every department should have a health representative. The municipality should have a health representative. The rural development should have a health representative. The water supply should have a health representative. Right. That is when you give a complete 360 holistic perspective to health in all policies. And I am again going to, I'm again going to refer to the slide which Camelin showed, and she made our life much easier by showing that very nice chart. The aspect of the social determinants of health. She actually spoke about the social determinants of health. It's very crucial to understand that the social determinants of health needed to be addressed to address healthcare disparities. So health in all policies actually means to address the social determinants of health also. Right. The third, I think, which is very important for many, many countries across the globe is doctor-patient ratio, to percolate it down to the primary healthcare centers, which is what globally doctors are struggling. And I think we need to involve innovative models in healthcare. I'll just give you one example. I was at the Harvard Business School a couple of years back, and I had a very interesting interaction with a group that was working in Africa, a healthcare group. They told me that they went to Africa, to one of these countries, and they tied up there with the mobile healthcare providers. And what they did was they actually collaborated with the mobile healthcare providers and health insurance. And they made a combined program in such a way that the more you speak, the more your health insurance got covered. Now, this was a win-win situation that they developed. And they were able to deliver better healthcare because people started interacting more on mobiles, and that was able to create a model on its own. I mean, I thought it was a win-win model for looking at, and that's where we will need to innovate on models. Generic medicines is a crucial aspect. Generic medicines is going to be one single game changer, because medications are going to push a person further into poverty. So generic medicines are a game changer when quality control measures are going to be brought into them. Generic medicines can be a game changer.
Right.
Democratization of data.
Yeah.
Democratization.
Dr. Sorry to interrupt that, but at that note, we are getting a few questions from our audiences, and that's a good thing, right? So one of the questions that was popped in the chat box was that what are the barriers to some patients accessing services? So I believe what the question means is that, patients are trying to access some healthcare services, and there are certain barriers. So what are the barriers? They just want to discuss about that. This is open to all the panelists. Anybody can answer this question. What are the barriers to some patients accessing services? So that's the question that I have received.
Dr. Kamilin, would you like to take this first?
No, I'd like you to, Dr. Ryle.
I thought the difficult questions goes to her.
What barriers are the patients facing, by the way, to get access to service?
I think from my perspective, what I would like to say is the biggest barriers that people talk about today is, if you look at the grassroots level, it's been access to fundamental good quality healthcare at the grassroots level. I'm talking, if I have to take the structure of this at the primary healthcare center, if you are able to get a good diagnosis, you have actually made a larger difference, because the cascade of delayed diagnosis, the cascade of poor outcomes begins there. So immediate access to healthcare, to good quality healthcare, and that boils us down to how can we have the best of healthcare taking down using technology to the most peripheral borders of the state or the country. That is where a lot of people, and the second aspect is, if you know, in urban areas, how do you access affordable healthcare? I think these are the fundamental two areas that we are looking at, urban versus rural. I think that's where I would like to present this.
Okay. So there are barriers, challenges, both at the fundamental level. I get that. I hope that answered the question to our audience. And there's another question. When we can achieve disparity-free health system in underdeveloped and developing countries? I think it's a relevant question. People
say
are
that
asking.
again. I'm sorry. Say that again.
I will repeat that.
Okay.
There's an audience who's asking when we can achieve, when can we expect to achieve a disparity-free health system in underdeveloped and developing countries?
I would express on that actually, because being in NHS health services in UK, what I have seen is, Dr. Vishal Rao was just mentioned, we have to reduce the hospitals, not to build up more. Yeah, I agree with that. Why? Because the lack of care in the community is just leading into people to queuing in the hospital. So, but that's not happening in NHS health services in UK. So we have a lot of services provided, and we have a expanding role of the nurses and therapists and specialists, supporting the people in the community. So they are getting help already, and they're being listened to by someone. So they are achieving what they wanted actually. Dr. Kamilin also mentioned about the socioeconomic determinants of health. So like, poverty, low income, and education, and even there's so many things that she has mentioned in her list actually. So that's affecting the people. So the health disparities, if we have to sort out, if you wanted to have a clear society, I think they need to get access in the community more rather than queuing into hospitals. So because there is a lack of access in the community for people, and the healthcare workers are not reaching to the people, that's why they are just becoming very ill. And even the mental health problems they are developing, it's affecting their social life. And then automatically they are just, deteriorating in their physical health, and then they end up having in a hospital. So I think we need
one nice thing you said, Amuda, one of the nice things you said is that we have hope. So
yeah, well, it's all happening in some of the countries. I think in developing countries have to focus on that, and the healthcare leaders and policy providers, they have to get help from the government to just review all this to reach to the population in their own countries. So then we all can work together, of course.
Right.
And I would
Dr.
just
Vishal Rao, there's a question for you. Oh, sorry, Kamilin, you were saying something.
Oh, I was just going to say that I would just add to that it certainly is important for health disparities to go away. First, you have to recognize that there are issues. And once you start recognizing that and put it on the table, then you can start addressing each of them. And some of the health factors that I mentioned weren't really on the table before. We just kind of trying to deal with some of their behavior and changing those things. But I think if we can look at some of the policies and laws that are out there, as Dr. Ryo also mentioned, and Dr. Robert, that when we start doing those things, then we can start truly addressing health disparities. But it starts really with some of these policies and changes in programs, policies and programs in our communities.
Right. We have to do things at the root level. I get that. Dr. Vishal Rao, there's a question for you from the audience asking, what's your thought on lifestyle changes required for cancer as your expertise?
So that again connects with the previous question of health disparities and how do you bridge it. I'm just giving a very simple model. Today, I'm talking about my own profession. I mean, I'm a head and neck surgical oncologist. I run this department. I see on an average about 30 to 40 patients per day of cancer. Now, majority of these, 95% of them are related to tobacco. 95% of them. Okay. Now, my fundamental question to myself is, should I be looking at increasing my practice further, or should I be looking at understanding how can I reduce this OPD of mine? And if I work on tobacco control, I can save more lives than by removing their jaws all through my life.
Right.
So fundamentally, I believe, I'm talking against my own profession now, and saying that if I have to bridge healthcare disparities, I need to say and I've been doing this and working with the government and saying that, look, my livelihood runs with making more surgeries and giving more chemos and radios. And I'm asking you, would you like to put me out of a job? And how could you do that effectively? You have to work on tobacco control, and that's the answer for it. That's the way you bridge healthcare disparities. And the fundamental important, and I think I'm bringing it to a larger philosophical discussion here to say that lifestyle changes are important because, in the capitalism model, we believe that you make a profit out of somebody's problem. That's capitalism. That's hardcore capitalism. Conscious capitalism says, and that means that the problem should persist. You should not solve the problem. Keep the problem, because that's where the profit is coming from. Now, healthcare cannot thrive on such a philosophical capitalistic model where we say, let the disease lurch because there's profit coming out of it. If you have to bridge disparities, you need to go to the fundamental philosophy of this particular question and say that let us not have disparities here, because I don't want to make profit out of this problem. Wow. And for that, government will have to take a joint approach and say that on one side, I will look at health, and on another side, I will look at sustainable health, which means delivery models which look at payments where they own it, which governments today don't want to do, because they realize health is a costly affair. No government wants to own health.
I agree.
Except for NHS, which has taken a bold step.
Right. So your simple answer to the people who asked this question was, let's work on this getting tobacco-free lifestyle to start off with.
A lifestyle, absolutely. A lifestyle wherein we talk about health in per se, where we look at less pesticides, less preservatives, less amount of adulterants. And that's where we do this.
Okay. I hope that answered the question, dear audience. There's another question that the people are asking. Is increased privatization of healthcare going to bridge these disparities? So the question is increased privatization of healthcare going to bridge these disparities, the healthcare disparities?
Can I come in?
Yes.
Can I come in on that? I think what is important is to understand that why is healthcare getting privatized? A lot of the times it's because of delivering quality, because quality was not being able to be delivered by government healthcare alone. And quality healthcare a lot of the time requires incentivization. So private sector somewhere was able to cater and live up to this goal of quality delivery much better than governments could do. And that's the witness we've seen in India also, that to deliver healthcare. Now, if I have to get an All India Institute of Delhi kind of a care or a Tata Memorial Care, how many states would deliver something like that? It's difficult. So you would require, private systems or an Apollo for that matter, or a Fortis or any other private small hospitals for that matter are today able to deliver some quality healthcare benchmarks. So naturally, yes, partially the answer would be that private sector expansion would hopefully be able to deliver quality healthcare, provided that it doesn't burn a hole in your pocket.
Right. That's very well put. Thank you. I hope that answered the question. We have a lot of questions pouring in, but unfortunately, we're running out of time. And I'm so happy that the conversation is going so interesting. But then we have to conclude this session in just a little bit. I would like to thank everybody. I would like to thank the audiences for being so active and so alert in this throughout this conference. And when it comes to our panelists, well, I'm running out of words to thank them because they have brought, all the panelists have brought their experiences, their contribution, everything, packed in just 5 to 10 minutes or, a little more maybe, in delivering this to the public, to people. I think that's great. The way Camelin brought, gender sensitive, not gender, I would say the social aspects, the healthcare aspects, the way she brought in very subtle things like the physical environment makes a huge difference. Social and economic factors make a huge difference, 40% of the difference. And the word difference itself. So these are some very interesting things that have come up. And I also would like to thank Ms. Amuda for her perspective, especially the way she has looked at this entire situation, the way she has contributed during this pandemic. And I also like to thank Dr. Vishal Rao for being so patient and answering every question. Thank you so much. And I thank the audience again. I thank all the people who are involved in making this conference a grand success.
Thank you.
I really want to, thank the Let Us Dream conference for giving me this opportunity to be a moderator. And this topic connects with me so much, probably because I am totally into mental health service. I understand what it means to be educated when it comes to health issues. I understand what it means to know the difference that exists in our society. I understand that at what level we need to get in. And it's really amazing to have this session with the wonderful panelists here. Thank you so much. Thank you.
Thank you, Seema. Thank you.
Thank you. Thank you, Seema.
Seema, you've been a great host. Thank you very much.
Thank you. Thank you very much.
It's been a pleasure being with all of you.
Thank you, Camelin. Pleasure connecting with you.
Yes,
Stay in touch.
And your information was wow, outstanding. Thank you for sharing with us.
Welcome to our Unsung Heroes celebration. Likely, most will agree that common characteristics of heroes, including admirable qualities such as bravery, courage, determination, moral integrity, selflessness, empathy, and servant leadership, just to name a few. Oftentimes, a hero is admired and recognized for great and brave acts. Literature is replete with examples of many kinds of heroes, such as the mythological Greek hero Hercules, known for his strength and courage, and the non-fictional hero Florence Nightingale, known for her leadership and compassion and care for suffering patients. And who among us has not heard of fictional heroes such as Superman and Wonder Woman, both of whom exhibit superhuman strength and strong moral character. Yes, we have many examples of heroes across cultures, But what does it mean to be an unsung hero? As heroes, oftentimes they exhibit moral courage, determination, selflessness, empathy, and servant leadership qualities, similar to those of their more celebrated counterparts. However, unsung heroes typically go undetected in their communities. They fly beneath the radar. Unsung heroes are people who do extraordinary things for others without seeking or anticipating credit, reward, or recognition. The Let Us Dream Conference is grounded in the value of volunteerism, specifically performing selfless acts of service, of community improvement and empowerment. Or, as Archbishop Damon Tutu would say, so simply say, doing little bits of good. Therefore, it seems highly relevant that we have chosen to honor individuals who reflect this value in their everyday lives without expecting acknowledgement of what they do, for they do it from their heart. According to the late great American poet Maya Angelou, if you find it in your heart to care for somebody else, you will have succeeded. It is this measure of success that so clearly aligns with the values that underpin this conference, and it is why we are profoundly grateful for the opportunity to have you join us this year in the celebration of our unsung heroes.
In the year, I think 1999 or 2000, decided to jump into the fray and start community work even though we had no experience. We decided to come and settle down in Bangalore, and that's how we registered this trust called Swabhiman. Swabhiman today, in the last 18 to 19, 20 years of its existence, we started off by adopting 15 girl children who are now all grown up and very well settled in life. Then we started working with schools where we taught English initially. We went on to hire teachers on our payroll. Then we started charity clinics. We run a fairly large interest-free microfinance activity. We run a very large educational scholarship. There are youth and women empowerment programs that we run. There are youth soft skill training programs that we give. We also run a fairly large food distribution program that supports about 2,000 people almost every single day, and run a grocery activity which delivers 1,000 families in that community groceries every month. So all this happened one by one, and that we kept addressing the needs in the community. The slum that we work with, which is the Rajendranagar slum, is one of the largest in Bangalore. And as we felt the need for various things at different points in time, we started the programs one after the other. And thank God that all these programs are flourishing and doing exceptionally well. Swabhiman, for a good number of its community activities, depends largely on the youth volunteers from the community. A majority of them are semi-literate or illiterate youth in the community who drive a bulk of our programs. So many years ago, about 10 years ago, we were doing a few things in the community like working with schools, having a couple of our clinics, and a small set of activities. One evening at about 7 o'clock, when I had finished my work and I was walking back through the slum with a set of volunteers, one young man by name Khader, an exceptionally poor boy himself with a couple of children, and was struggling to make his two ends meet, I saw him holding a couple of food packets in his hand. Now, this was a time that we were struggling to serve 50 meals in that community, we used to cook food ourselves because we were realizing that there was some amount of people who were going hungry there. So when I saw the food packets in his hand and I asked him as to, Khader, what is this food packet? He told me that, sir, for the last couple of years, every day when I cook food at home or my wife cooks food at home, she lets me pack 2 meals and I deliver it to a couple of destitute women who sleep under a staircase in a building. And I was very intrigued. Khader, who himself is very poor and just about manages to give his children 2 square meals, how could he do this? So when I went along and met these women, and they were absolutely destitute and they were waiting for Khader's hot meals. After he served the meals, I asked Khader, I said, when you yourself are making it so difficult for your family to, make 2 ends meet, how do you serve food to others? His answer is what changed a lot of our activities and my life forever in that community. He told me, sir, if my parents were alive, would I not have given them 2 meals every day? So I now believe that whenever my wife cooks, these 2 additional meals are meant for my parents, and those are the 2 meals that I pack and deliver these destitute women. That day I realized that when Khader can manage to serve 2 people in the community every single day on his own, can I not drive a program to feed a large number of hungry people in the community, mostly senior citizens, widowed women with little children, so on and so forth. So a program that started 10 years ago with 50 meals serves almost 2,500 meals every single day. This is one such life-changing experience, though I can narrate very many more, but this is one of those very, very touching ones. Thank you.
Hi, my name is Enes Banda. I do work with the Malawi Children's Mission Organization, which is a local non-profit organization working with orphaned as well as vulnerable children. I would like to share with you some information relating to the program that I'm working with. I do work as a coordinator for the Young Women's Initiative program. But before I tell you a lot on the Young Women's Initiative, I would like to take this time to appreciate those who are involved in choosing members to take part in the upcoming Let Us Dream International Conference. I felt honored to be recognized as one of the people that are doing work that is impacting the community. Thank you very much. Now coming to the Young Women's Initiative program, this is an initiative that was put in place in 2015 by the Malawi Children's Mission Organization. There were a number of reasons why this initiative came into existence. Previously, the organization has been experiencing huge numbers of girls dropping out of the system due to teen pregnancies as well as early marriages. So as a way of trying to keep the girls in school, the initiative came into place. We have 45 girls currently in the program, and their ages range from 12 to 22. We hold 2 meetings each week, but also hold special meetings 1 Saturday a month. Our weekly meetings are based much on teaching the girls topics related to their education, health, as well as life skills. Whilst the Saturday meetings are much focused on mentoring the girls. During these Saturday meetings, we do invite ladies as guest speakers, especially those ladies who have gone through the similar kind of backgrounds as our girls, but have made it in life. We want them to motivate our girls that no matter what the circumstances are, they are still standing a chance of becoming independent in the future if they work hard on their education. So initially, that is the main reason why this initiative came into place. We just want our girls to grow into independent but also responsible members of the society. So working with these girls just reminded me of where I'm coming from. I saw myself in them and I was really happy to work with them to encourage them, to motivate them, because I could see that they are standing a better chance of becoming better people in the future, because they are belonging to an organization, yet I did not have that chance. So to me, I felt like if they are just given encouragement, if they are mentored, if they are like exposed, believe you me, they have each and every chance of becoming better people in their societies. So yeah, after graduating in 2017, I was given a chance to continue working with these girls as a coordinator for the Young Women's Initiative Program. I'm happy to be working with these girls, and I enjoy spending time with them and doing whatsoever we're doing with them. I have huge expectations on them. I believe that they will be notable people, great people in the coming years. People graduating from the Young Women's Initiative Program, becoming great in the society, and also taking the responsibility to mentor some other girls that are coming, be it in the organization or maybe in different areas in Malawi.
Renuka Jagannath is a computer engineer who limits herself in the field of technology and pursues her interest in social work. Because of this, she became a voice to the voiceless and a brainchild of UDID NGO, which aims to explore the world and provide a bunch of love, care, and support. UDID, Youth Undertaking Developed India Dream, is a non-governmental organization founded in 2018 in Bangalore. It comprises highly disciplined and well-qualified like-minded people who have been a leading change maker in creating awareness in education, governmental policies, cleanliness program, supporting food relief. It has targeted setting up camps, building community halls, bus stands, and necessary facilities in India's rural region. Recently, it met tremendous attainment while conducting a quiz competition aiming to raise a considerable amount of money for serving the needy in COVID-19. These days, it has been doing awareness programs like mental health, coloring, painting, interviewing with doctors going virtual. Finally, it believes in giving back the portion of what we have earned. As its main motto is, let the change flow. Chandni Ravi is the Deputy Director at Ernakulam Medical Center, a family-run multi-specialty hospital in Kochi. She graduated in Electronics and Communication from Cochin University. 2017, July 17th, her life took a spin. While she was doing her PhD, she was diagnosed with breast cancer. She was determined to keep her husband and her two little children together, and for this, she had to take care of herself mentally, physically, and spiritually. The day she was declared cancer-free, she started Pink Sari Sisters, an online support group for Indian women diagnosed with cancer. Group's primary goal was to keep families together. She would go to towns' remote parts to teach children. Most kids are from challenged backgrounds, drugs, broken families, and low socio-economic backgrounds. She helped sell the produce of one orphanage and distribute in a needy orphanage elsewhere, supporting cancer patients and their carers. Sustainable Menstruation Care Collective, SMKC, brings together educators, practitioners, activists, youth, and organizations to open up missing dialogues on menstrual rights and equality. They run online and offline outreach with their members to offer mentorship to young educators, collaborate for policy advocacy, and facilitate knowledge sharing in menstrual health care and sustainability practices. Their collective remains committed to holding open, safe, and informal spaces for women, girls, trans and intersex persons, for informed exploration of menstruation beyond taboo and with reason, as well as engage non-menstruating allies for creating support systems. Mr. Vinod Kumar is an academician by profession, works as an assistant professor at a university. He teaches accounts and finance. He is the founder of the Good Quest Foundation, a registered non-profit charitable trust working for the empowerment of underprivileged and marginalized society, with the vision to seek the lost and empower them. Vinod and his small team of enthusiasts are determined to get a tangible change in the derived classes' lives. He works among the slum dwellers, juveniles in remand homes and young prisoners, transgender people, refugees, orphans, needy, and tribals. One of the core areas where Vinod is focusing on is disaster and pandemic relief work. Since the outbreak of COVID-19, Vinod's contribution to the society in providing relief amidst the distress is extraordinary.
I'd like to now introduce our keynote speaker, Dr. Devi Prasad Shetty, Chairman Narayana Hrudayalaya, Bangalore, Karnataka. A cardiac surgeon of repute and a successful entrepreneur, Dr. Shetty is a highly respected luminary for his ingenious ideas for reforms in healthcare sector. His visionary leadership to make quality healthcare affordable for all has drawn global recognition. Treading the path of economics of scale to bring down the cost of healthcare delivery, Narayana Hrudayalaya has been an interesting case study for the likes of Harvard University and the Wall Street Journal. In association with the government of Karnataka, Dr. Shetty pioneered Yashaswini, a very inexpensive micro-health insurance scheme benefiting more than 3.5 million rural poor. Dr. Shetty is the current chairman, Board of Governors, Indian Institute of Management, Bangalore. He has also served as a member, Board of Governors of Medical Council of India and representative of President of India in the Board of Governors of Indira Gandhi National Open University. The Government of India, state governments, trade bodies, and global policy think tanks invite him regularly for discussions on healthcare policies. He was part of an international advisory group, a strategic advisory platform invited by Japan's Center for International Exchange to address the global health agenda under Japan's G20 leadership during 2019-2020. A strong advocate of technology for efficient healthcare delivery, Dr. Shetty takes deep interest in creating and developing software products and applications to achieve time and cost efficiency while minimizing clinical errors in healthcare delivery. Dr. Shetty is the recipient of several prestigious awards, including the Padma Bhushan, Padma Shri, the Economist Innovation Award, Ernst & Young Entrepreneur of the Year, Financial Times Accelerator Mittal Boldness in Business Award, Nickel Asia Prize for Economic and Business Innovation. He has also been awarded honorary doctorate from University of Minnesota, University of Mysore, and IIT Madras.
Ladies and gentlemen, COVID-19 has changed this world forever. Today, I'm sitting in our health city. We have 4 hospitals in one campus. There are close to 400 COVID-19 patients in our campus in a separate building. Over 100 of them are in the critical care unit. Nearly 300 of our doctors, nurses, technicians are already infected with COVID. I wish and pray to God that the number of COVID patients will come down. However, if it continues like this for some more time, we may not have doctors, nurses, and technicians to take care of the patients. We are optimistic. Number is coming down, especially in city of Bangalore and in Delhi and few places where we have hospitals. We have seen numbers coming down. Let's keep our fingers crossed. Now, let me talk to you for the next few minutes about exciting things, what can be done to transform the global healthcare. I would like to ask you a question. If you are the Health Minister of India and you are given every right to change anything what you want, what is it you will do to transform the healthcare of India and of course global healthcare? But you are allowed to do only one thing. What is that one thing? That one thing is removing the pen and paper from the hands of doctors, nurses, and medical technicians and give them a digital tool which is smart. If we can do that successfully, believe me, healthcare will become safer for the patients. It will become affordable for the patients, and it will also become accessible to the patients. All we need to do is to come up with a smart digital tool. Just replacing the paper and a pen with a dumb digital tool is not going to make any difference. But a smart digital tool will make a difference. I strongly believe that a smart software can make smarter diagnosis than doctors within the next 3 to 5 years. And I am convinced within 7 to 10 years' time, it will become legally mandatory for every doctor to get the second opinion from the software before starting the treatment. It is going to happen. Why I am so confident that smart software can make smarter diagnosis than doctors? Now let's look at diagnosis. When a doctor like me makes a diagnosis, how many diseases are prevalent in medical practice? I'm not talking about esoteric diseases which are diagnosed only by the machines. I'm talking about in my clinical practice. Generally, there are not more than 2,500 diseases what we commonly encounter. This is not infinite. This data is finite. And how do we diagnose? We diagnose it by listening to the patient's complaints. This is called, in medical terms, it is called symptoms. There are, irrespective of how fussy your patient is, he or she cannot complain to you more than 650 complaints or symptoms. Then, as a doctor, I examine the patient and we elicit findings like, okay, the patient is jaundiced or is anemic or there is a swelling. These are called signs. Generally, we elicit about 510 signs. Then we send the blood tests, urine tests, sputum tests, all kinds of tests. Generally, there are about 2,500 tests. We get the data of about 2,500 lab reports. And then we look at the images, X-ray, ultrasound, CTs, MRI. Generally about 450, 500 varieties of images. to diagnose the patient's problem, all we have to do is to put the signs, symptoms, lab tests and images together, analyze it and come up with the diagnosis. Believe me, the software in your mobile phone can do that for you. It's a matter of time. I keep talking about hospitals not safe for the patients. Everyone thinks if you are unwell, hospitals are the safest places for the patients. But that is not true. Let's look at American hospitals. American hospitals are perhaps the safest hospitals on the planet. If 200 patients get admitted to an American hospital, spend just one night, 1 in 200 dies due to medical error. Getting admitted to an American hospital is 10 times riskier than skydiving. Why hospitals are not safe? It's because doctors and nurses do not follow the protocol sometimes. Why? Because protocol is written down, it's all available in a nicely bound files, but that's all in a cupboard. If this protocol-based software is the only matrix on which healthcare is delivered, believe me, we can virtually eliminate medical errors. According to British Medical Journal, medical error is the third leading cause of death in United States of America. Next question is, if digital tool is that important to deliver healthcare, why this is not available to everyone? You will be surprised and shocked to hear that nearly over 80% to 85% of the hospitals in this world do not have electronic medical records. Most hospitals do not even have hospital management system. If they have a hospital management system, they do not have an electronic medical record. Some hospitals may have an electronic medical record. They may even have a hospital management system, but they don't talk to each other. They are supplied by different vendors. This is the problem. And the biggest problem is some of the very good so-called most modern electronic medical records used by hospitals in US are worth millions and millions or billions. Yes, they are worth billions of dollars. Now one would think that an electronic medical record which is worth millions and billions will dazzle the doctors. Doctors are so happy to use it, they should celebrate. But that is not the reality. Unfortunately, electronic medical records are one of the common reasons for doctors' burnout in the United States. It is so badly designed and so difficult to use, doctors hate them. If they spend 1 hour with the patient in examining, they have to spend another 2 hours in entering the patient's data. There is something dramatically wrong somewhere. If EMRs worth millions and billions are not the ones which doctors enjoy using, now let's ask a question. What do the doctors want? How do they want the electronic medical record to be built and designed? There are few fundamental principles. First fundamental principle is, when you design electronic medical records for the doctors, that shouldn't have a keyboard. Because doctors are not designed by God to type. So the electronic medical record should work only by touch. The second requirement is, if you are going to give an electronic medical record with the instruction manual, with a request to the doctor that he has to spend 76 hours of training how to use the electronic medical record, like what happens with $1 million worth electronic medical records from US. Believe me, no doctor is going to use it. First thing they will do is to throw your instruction manual out of the window, and he will never use your electronic medical record. Electronic medical record for the doctor should be intuitive. Like how we do many things in our mobile phone. Most of the mobile phones, smartphones, do not come with the instruction manual. Just by intuition, we know how to use it. That is the way EMR has to be designed. The next important quality of a EMR is it must be built on a mobile platform, and doctors can view it in their own mobile phone. Why mobile phone? It's because you want the best care for your patient. Doctor's attention should be drawn to the patient regularly. Doctors across the world look at the desktop 5 to 10 times in a day, but they look at their mobile phone screen 200 times in a day, at least. So if you design your electronic medical record so that the doctor can see the patient records, wherever he is, many times in a day, patient will get the best care. And one of the most important requirements of us with the digital medical record is that it should be affordable. It should be affordable by every hospital on the planet. With that in mind, we have toiled for more than 10 years in developing an electronic medical record which is smart, which is mobile, which is affordable, which is intuitive. So we came up with the concept of Atma, which is the hospital management system, the Adi, which is like an electronic medical record, then Meda, which is an analytic tool. And our aim is to make sure that these modern electronic medical records, hospital management system, will be available to any hospital on the planet, especially developing countries, at a price what they can afford. Now, what is the price what a hospital can afford? We believe that no hospital can afford to buy the EMR. It is too expensive. But they can all use it on a pay-per-use model. They pay a fixed amount per patient per day. Now, what is that amount what they can afford? We believe that if we can charge the hospital the price of one disposable plastic syringe per patient per day, this is the amount of money hospitals can afford to pay. Because we know that when the finance team of the hospital do the costing of a procedure, they do not add the price of a disposable plastic syringe because it is too small to be added. If we can keep it at that price and constantly keep upgrading it, updating it, we believe that within the next few years, we will be able to take away the pen and paper from the hands of doctors, nurses, and medical technicians. And this is our mission, and we hope to achieve it within the next 3 to 5 years. Thank you very much for this opportunity. I am extremely grateful to you. Have a wonderful day.
I would like to introduce our closing comment speaker, Dr. Father Abraham VM, Vice Chancellor, Christ Deemed to be University. Dr. Father Abraham VM has a master's degree in mathematics and MS in computer science from Iona College, New York. He obtained his doctorate from Bangalore University, India. He has been working with Christ University, Bangalore, and since 1989 in various capacities, and has been serving as its Pro Vice Chancellor from 2008 to 2018. Currently serving as Vice Chancellor of the Christ Deemed to be University. He has served as a member of various academic bodies like Scientific and Technical Community and Editorial Review Board on Natural and Applied Sciences, World Academy of Sciences, Executive Committee member, Conference of Catholic Colleges of Karnataka, etc. Dr. Father Abraham VM is a member of a religious congregation of Catholic priests called the Carmelites of Mary Immaculate.
Ladies and gentlemen, I am very happy to be part of the Let Us Dream Triennial International Virtual Conference 2020. I understand today, the second day of the conference, the discussions and deliberations were on the topic mindfulness for health, physical and mental well-being. I congratulate the organizers for identifying this significant topic to the floor for discussion. As an administrator, I have come across many instances of fainting spells and hysterical outbursts from students and faculty on campus. At Christ University, we have support systems with the counselors and clinics to tackle such instances. Lately, I have seen a rise in the number of cases of clinical depression. This is something of concern, especially now in this time of the pandemic. COVID-19 is spreading across the world, and with it, we also see the spread of worry, anxiety, and instability. As the mind wanders and gets trapped into patterns of negative thinking during times of crisis, there are feelings of fear and helplessness. Fear narrows our field of vision, and it becomes harder to see the bigger picture and the positive, creative possibilities in front of us. As perspective shrinks, our tendency to connect with others shrinks too. As I observe the number of COVID-19 cases spiking in Bangalore, India, I am reminded of a parable of the Buddha. Like Christ, Buddha also used parables to teach his disciples, and one day asked them, if a person is struck by an arrow, is it painful? If the person is struck by a second arrow, is it even more painful? He then went on to explain, in life, we cannot always control the first arrow. However, the second arrow is our reaction to the first. And with the second arrow comes the possibility of choice. Our first arrow is the coronavirus and the restrictions we are experiencing these days. We are affected by the travel restrictions, supply shortages, and physical distancing. The anxiety about getting the virus ourselves, worry that our beloved ones will get it, worries about financial instability, and the bleak stories the news and social media is to a large extent our own making. This is our second arrow. It is important to remember that our second arrows, which are our emotional and psychological response to the crisis, are although natural and human, bring us only misery by narrowing and cluttering our mind and keeping us from seeing clearly the best course of action. The way to overcome this natural tendency is to build our mental resilience through mindfulness. Mental resilience, especially in challenging times like the present, means managing our minds in a way that increases our ability to face the first arrow and to break the second one before it strikes. The present climate of fear can create stigmas and judgments about who is to blame and who is to be avoided, making us forget our shared vulnerability and interdependence. I believe that meaningful connection can occur between us and our neighbor when social distancing decreases and physical distancing is maintained. This mindset happens with compassion. Our compassion is our intention to be of benefit to others, and it starts in the mind. We are being mindful of how we can help another person to have a better day. The mind then expands, the eyes see what is really in front of us, and we see possibilities for ourselves and others that are rich with hope and opportunity. I hope today we concluded that our dream of universal well-being is indeed achievable by building mental resilience through mindfulness. Thank you.
We are nearing the end of today's program. However, before we close out the day, allow me to introduce our final delightful and captivating video. It features an ensemble of entertaining and talented musicians performing together from different locations around the world. This inspiration ensemble was coordinated by the Dreams Band. The Dreams Band, an integral component of the Let Us Dream International movement, was established for the purpose of empowering children and youth in various communities in different parts of the world, with the help and support of their respective local community musicians. Credit goes to the Dreams Band for facilitating the coordination of an incredible international community of musicians and singers who voluntarily participated in the creation of this video. While this is an international group with likely different cultural backgrounds, they all subscribe to a belief in the power of music to transform, inspire, and help heal the world, particularly during these challenging times. To that end, they have prepared this musical collaboration expressly for you. So sit back, relax, and enjoy the music.
Hey,